Hello class, and welcome to Quiz 3 Prep. So we use a 25 long needle for the infraorbital IO injection at MCC. We select the 25 gauge because it reduces the amount of deflection of the needle as we travel through the muscle fascia. The area is not highly vascular, so the risk of positive aspiration is low, and a one-plane aspiration is sufficient. We use a long needle because the depth of penetration varies widely between people. So we begin with the long needle to determine how much of the needle is inserted to reach the infraorbital foramen. If approximately 14 millimeters is needed, then it is acceptable to make a note in the patient's record that a short needle is acceptable for an IO. Conversely, imagine if you start with a short needle, you haven't contacted bone, and you are close to the hub. And remember, the hub is the weakest part of the needle. Now you have to start all over again with a long needle. So feel for the infraorbital notch on the inferior border of the orbit. Roll your finger down 10 millimeters. 10 millimeters is about the width of your finger until you are on the infraorbital foramen. If your finger is down by the ala of the nose, you are too low. Your patient may tell you that they feel a little zing when you are directly on the foramen with your finger. Once you have achieved excellent retraction, you will insert parallel to the long axis of the premolar. You will need to be sufficiently lateral to bypass the zygoma. So what gets numb? Essentially, the pulp, buccal periosteum, connective tissue, mucous membrane of the maxillary central, lateral, canine, first and second premolars on the injected side. Additionally, in 28% of patients, the mesiobuccal root of the first molar, the cheek, side of nose, and lower eyelid will also get numb. The lower eyelid is key. If that is numb, then you have penetrated deep enough and reached the foramen. You get a lot of bang for your buck with this injection. Minimally, you will deposit a half of a cartridge to achieve adequate anesthesia. This makes this injection great for medically compromised patients or patients that do not want multiple penetrations. You may feel a small mound form under your finger as you deposit solution. This is perfectly normal, and as you apply pressure, the mound will flatten out as the anesthetic is pressed into the foramen. Please maintain the pressure for 2 minutes after depositing solution. This helps push the solution through the foramen and bathe the infraorbital nerve with anesthetic. I also believe this minimizes the uncommon and very low risk of a black eye. If you contact bone too early, the needle is not lateral enough to bypass the zygoma. If you deposit too low, the patient may report the side of their nose is numb, but nothing else. You may need to come out of the tissue completely and reinsert more lateral. Sometimes you may be able to redirect the needle without removing it from the tissue. Your faculty will help you with this. Local complications include hematoma, so pressure after you've made the needle safe. Sometimes the small terminal fibers of the facial nerve can be anesthetized, so half the face looks a little droopy until the anesthesia wears off. According to your textbook, tapping the bone prior to depositing solution is not required, but at MCC, our protocol is for you to tap bone for the IO injection. This allows us to know where the needle is inside of the tissue and is part of our safety protocol. Please know for the quiz, that a bone tap is required for the IO.